is well known that the assessment of elbow instability may often be very difficult, and two of the greatest elbow masters, Bernard Murray and Sean O'Driscoll, remind us on how challenging its treatment may be, especially if compared to a stiff elbow. Now, before planning any rehabilitation protocol, there are some key points that must be well known, such as the pathoanatomy, a thorough knowledge of the surgical procedures, the presence of any associated lesion, and anyway, it's imperative to know that any elbow instability always requires a tailored rehabilitation program. And there are, regarding elbow instabilities, there are some general guidelines such as a sequential and progressive approach, the requirements of the soft tissues and their physiological healing, and all this has to be known to achieve a safe and quick return to sports and to activities of daily living. Now, it's important to point out, to underline how the functional range of motion dramatically changed in the last decades, and this due to the fact of the daily frequent use of the cellular phones and the computer keyboards. And as you can see from the previous paper from Murray, the functional range in flexion extension and in pronation and supination dramatically changed and increased, and we have not to forget that 50 degrees of compressive deficit can result in an 80% of functional loss. Now, diving into the complex elbow instability, we have to say that its treatment is always surgical. There is no place here for conservative treatments, and the goals of rehab are, first of all, to achieve a stable elbow, to allow, when possible, early motion, and of course, to prevent stiffness. So what to do in the immediate post-op phases? Of course, the early management of pain and swelling. We can use kinesiotaping or cold therapy. Other modalities here, such as laser therapy or ultrasound or something like that, are useless. They may be useful in a stiff elbow, but not in an unstable elbow. It's important to remember the shoulder and the muscles, of course, of the forearm of the wrist to have a complete approach to the upper limb kinetic chain. In the last phases of the rehab, we may introduce eccentric and plyometric exercise, and we have not to forget that the elbow lacks of mechanoceptors, and so proprioceptive and kinesthetic exercise are really useful for a good outcome. Now, while mobilizing from the therapist the elbow patient, we have not to forget the importance of the arm position, because while dealing with elbow instability, it's important to allow a good joint compression. So the benefits of overhead mobilization are, of course, very, very important, as well as to maximize non-noxious sensory input. And This is a very important aspect of preventing elbow stiffness, and in this case an electromyographic biofeedback may be useful for reducing the muscle guard. Now, the length of any rehabilitation protocol, of course, may vary from the damage, from the trauma, from the surgical procedures, and for the personal characteristic of the patient itself. And in these two slides, you can see how different may be the length of a rehab protocol depending on these aspects: the age of the patient, the surgical techniques, and the functional outcome, of course. Regarding the lateral collateral ligament, it is very important to underline to avoid the gravity-loaded varus, which may be very dangerous for the suture or for the reconstruction, as well as the forearm position. Forearm position is very important because during the flexion extension exercises, the forearm has to be positioned either in pronation or in supination in case of inadequate lateral collateral ligament or medial collateral ligament reconstruction, respectively. In the rehab treatment of elbow instability, cast and hinge brace may be used to provide a limited extension for the first 3 or 4 weeks, of course, depending on the surgical procedure, to avoid mechanical loads on the anterior coronoid, but also to protect the lateral collateral ligament, to promote early passive and active mobilization, and after radial head or coronoid fractures as well. As we know, the very wide presentation of elbow instabilities is correct to use the plural. We heard about a terrible triad, we heard about the elbow fixator in some cases, and it is very important for the physios to have so many informations as possible, because we have not to forget that sometimes we have to protect, as we told, for example, for the lateral collateral ligament, or in presence of an Essex Lopresti lesion, we have to protect risk of surgical procedures in the wrist, TFCC or something like that. It is very, very important, a good communication between the surgeon and the physio. And the physio, at the end of his treatment, when the patient recovers, it's very important that he has to be familiar, to become familiar with the elbow score. We, of course, and advises to use the Mayo Elbow Performance Score to have a personal database which may be very, very useful for further patients he may have to deal with. So the take-home message, very, very important: elbow instability does not exist. Exists any patient with its particular elbow instability. So tailored rehabilitation. The ulnar nerve is important. It is our red flag, as our warning sign that gives information if the treatment is running too fast, especially while achieving elbow flexion. We have not to forget that the elbow is a part of the entire kinetic chain of the upper limb. The prevention of stiffness is imperative, and we always, in all the phases of the rehabilitation, biology and biomechanics has to be respected. and some little tips for the younger physios. The patient position, the limb patient position for manual therapy, for exercises, is very important, but always remember to avoid overhead position for at least 5-6 weeks if in presence of olecranon fractures or triceps approach. Always communicate with surgical team regarding the safe zone in which working. In many cases, it's important, it's necessary to exercise the contralateral upper limb to use the effectiveness of neuromuscular facilitation, proprioceptive facilitation, and when possible, immediate motion for a proper cortical mapping. And once again, thank you very much for your kind attention.